Yes, Mauli. Welcome to classroom, and you can carry on with your topic.
Uh, good afternoon, everyone. Myself, Mouleeswaran. I'm an assistant professor in Department of Neuroanesthesia from CMC Vellore. First of all, greetings from CMC Vellore. I'll be starting my talk on immunotherapy in neurocritical care. Are you able to see my slides?
Mauli, we are not able to see your slides.
So I've uploaded it.
Share your screen, Mauli.
Yes, sir, I have shared.
Not able to see your screen. Yeah. Maybe you can close it and try again. Yeah.
Yeah. Now are the slides visible, sir?
No, Mauli, I'm not able to see your slide.
Okay, just a minute. I hope it is visible now.
No, Mauli, we are not able to see your slides.
Okay.
You get out of the stream and join again, Mauli.
Yeah.
A small technical glitch, please bear with us. Yeah. Now you do start sharing, Mauli.
I'm sharing the slides, sir. Can you see it?
No, we are not able to see it.
I'm clicking it and presenting the giving share screen. It's not showing.
Yeah, we can see your slides.
Okay.
Please proceed. Yeah.
Good afternoon, everyone. Sorry for the technical glitch. I am Dr. Mouleeswaran from Department of Neuroanesthesia, CMC Vellore. Now, I'm going to talk about immunotherapy in neurocritical care. So, coming to our NICU demographics, autoimmune neurological disorders form a major subset of population who get admitted to neurointensive care, and the case burden is as high as 30% in the West. Coming to the etiology of these diseases, they may be either primarily autoimmune, or autoimmune cause may be the one of the multifactorial causes for the disease. So the treatment modalities which are aimed at targeting the immune system form a mainstay of management of these autoimmune neurological diseases. They are called as immunotherapy or immunomodulatory therapy, and they are broadly classified into four subgroups: those which are aimed at inhibiting the T and the B lymphocyte proliferation, those which are aimed at inactivating the formed T cells, those which are targeted towards depleting the formed B lymphocytes, and miscellaneous group of drugs which have specific modes of action. So, coming to the antigen presentation and processing and the targets which are available in this process. Whenever an antigen is sensed foreign by the body, first the antigen presenting cell processes it, then it delivers to the CD4 T lymphocytes. From there, the pathway is activated either through B cell proliferation or T cell proliferation. So we have various modalities which can be aimed at targeting each steps in this process. Basically, like inhibiting the presentation of this antigen to the T helper cells, inactivating the proliferation of B lymphocytes, inactivating the antibody release from the B lymphocytes, as well as accelerated degradation of the antibodies which are released. So these thus forming the targets for immunotherapy. So coming to cell cycle inhibitors, this forms a group of drugs which inhibits the cell cycle, thereby preventing the mitosis of the cells. So as we know, immune cells are rapidly proliferating cells with a very high cell turnover. So interference with any part of the cell cycle can result in arrest of cell division and inability to form new lymphocytes, thereby resulting in arrest of immune progress. Basically, we have azathioprine, cyclophosphamide, mycophenolate mofetil, and methotrexate, which are commonly used to as cell cycle inhibitors in autoimmune neurological diseases. of which cyclophosphamide acts in all phases of the cell cycle, whereas the other drugs are specific to certain phases and certain checkpoints. We already know that there are 4 phases of cell cycle and 2 checkpoints. Basically, the G1 phase, S phase, G2 phase, and the M phase, where G being the growth phase, S being the synthetic phase, and M being the mitotic phase. So coming to the first drug, that is azathioprine. It's a purine analog. It inhibits the purine synthesis, thereby preventing the nucleic acid formation, and thereby reducing the formation of lymphocytes. So the mechanism of action being, azathioprine is converted to 6-mercaptopurine, which in turn is converted to 6-thioguanine, and conjugation with ribose and its phosphorylation forms thioinosinic acid and thioguanylic acid. These are the nucleotides which are responsible for the synthesis of DNA and RNA. So they replace the normal nucleotides in the DNA and the RNA, thereby rendering the DNA and RNA non-functional. So thus it inhibits the synthesis of DNA and RNA. Therefore the cell cycle progress gets arrested. So the elimination half-life is 26 to 80 minutes, and it's mainly excreted in the kidneys. The dosing ranges from 2 to 3 milligrams per kg per day. Major adverse effects are pancytopenia, hepatotoxicity, pancreatitis, secondary malignancy. Coming to the next drug, which is the mycophenolate mofetil. It's 2-morpholinoethyl ester of mycophenolic acid. It acts by reversibly inhibiting the IMP dehydrogenase, which is the key enzyme in the synthesis of purine nucleotides, thereby resulting in inhibition of DNA and RNA synthesis. Thus, the cell cycle progress gets arrested, and formation of new immune cells becomes inhibited. So it's 94% bioavailable, and it's a highly protein-bound drug and metabolized in the liver, and it is excreted mainly by the kidneys. The dosage ranges from 1 to 2 grams per day in divided doses. Major significant adverse effects being, it can cause leukopenia, pure red cell aplasia, sepsis, opportunistic viral infections, especially CMV and Epstein-Barr virus infection, thrombosis. The next group of drugs is the methotrexate, which is an anti-metabolite which inhibits conversion of dihydrofolate to tetrahydrofolate, thereby inhibiting both purine and pyrimidine synthesis. So this also arrests the cell cycle, thereby preventing proliferation of T and B lymphocytes. The dosage typically used in neurological disorders are 10 to 20 milligram per week, and major concerning adverse effects being myelosuppression, risk of secondary infections, renal failure, and pneumonitis. Next one is the cyclophosphamide. As we all went through the previous slide, it is a non-specific cell cycle inhibitor, inhibiting all phases of the cell cycle, and the effect is more pronounced on the B cells than the T cells. So the active metabolite of this agent, which is the phosphoramide mustard, forms DNA cross-link, thereby accelerating the apoptosis of the cells. So the half-life is 3 to 12 hours, mainly metabolized in the liver, and it is excreted in the kidneys. The dosage ranges from 500 to 600 milligram per meter square. It is administered as a pulse dose on alternate days. Coming to the adverse effects, the GI adverse effects, hemorrhagic cystitis, it can cause myelosuppression, alopecia, skin and nail discoloration, gonads and cardiotoxicity, can cause SAADH and predisposes to secondary malignancies. So coming to the use of cell cycle inhibitors in neurocritical care, it is recommended as a maintenance therapy for long-term use in myasthenia gravis patients, for long-term use in acute CNS demyelinations, and in immune-mediated neuropathies, CNS vasculitis, and neoplastic and non-paraneoplastic autoimmune encephalitis. So this is a study where they compared patients receiving prednisolone as well as prednisolone plus azathioprine as a maintenance therapy, and they found that the and they found that the prednisolone dose did not decrease significantly in the first year following follow-up, but gradually over the period of years, that is at 3 years and 2 years, basically the dose of steroid which is used for the patient to keep the patient in remission got significantly reduced, and the incidence of side effects related to therapy in patients receiving the azathioprine and prednisolone is significantly less compared to the other group. This is a study where they studied intravenous pulsed cyclophosphamide in patients of myasthenia gravis, and they found that in patients who have received IV cyclophosphamide, there is significant improvement in muscle strength at 3 months and 6 months, and at 12 months, and the amount of steroid therapy which is required to produce this same effect was significantly low when it was combined with IV cyclophosphamide rather than giving steroids alone. The next group of drugs acts by producing T cell based immunosuppression, which is the calcineurin inhibitors, and the second another group of drugs which acts by the similar mechanism is the corticosteroids. Among calcineurin inhibitors, we have cyclosporin and tacrolimus. So when coming to the T cell mediated immunosuppression, so whenever the antigen presenting cell presents the antigen to the T cell receptor, there is an activation of a membrane protein which is called calcineurin, which in turn causes increased upregulation of transcription factor, that is NFAT. This NFAT binds with the promoter region of the interleukin genes, thereby increasing the transcription of interleukins. So the cyclosporin binds to the immunoprotein called cyclophilin. This cyclosporin immunophilin complex prevents activation of this calcineurin, whereas tacrolimus binds to F-kappa B protein, which in turn binds to the which in turn results in reduction in production of the activated calcineurin, thereby reducing the transcription of interleukin genes. Steroids act by reducing the antigen processing by the antigen presenting cells as well as the macrophages. So coming to calcineurin inhibitors, when we compare cyclosporin with the tacrolimus, the half-life of cyclosporin is 24 hours, whereas it is short half-life in case of tacrolimus. And tacrolimus is a highly protein-bound drug. Dosage of cyclosporin being 1.25 milligram per kg twice daily, and maximum dose up to 4 milligram per kg per day. Whereas in case of tacrolimus, it is 0.05 to 0.1 milligram per kg per day. Notable adverse effects when it comes to tacrolimus is the systemic hypertension following like commencement of the drug therapy, and incidence of PRES, nephrotoxicity and hyperkalemia, as well as electrolyte disturbances and new onset impairment in the glycemic profile of the patient. Whereas in case of cyclosporin, it is convulsion, GI side effects, hyperkalemia, as well as renal failure. So this was a study where myasthenia gravis patients were treated with standard therapy, and they were randomly allocated into two groups. One group received the standard therapy along with tacrolimus. In the other group, they didn't receive tacrolimus, and they found that the need for plasmapheresis and high-dose intravenous methylprednisolone was significantly low in patients who have received tacrolimus compared to those patients who have not received it. And none of these patients exhibited any significant side effects to tacrolimus up to 1 year of the 1 year after the treatment. So coming to corticosteroids, these are one of the most commonly used drugs in the neurointensive care practice for any autoimmune neurological disorders, and they are synthesized from the adrenal gland in response to ACTH. They are available as natural drugs as well as synthetic analogs. The synthetic glucocorticoids are more potent and they are more selective in their action, and more free drug is available in plasma for action. So this is the comparative pharmacology where we have short, intermediate and long acting drugs and the equivalent glucocorticoid dose ranging from 20 milligrams of hydrocortisone, which is equivalent to 25 milligrams of cortisone, and the other group of drugs whose equivalent doses are described here. And we can see that some drugs are more glucocorticoid, the glucocorticoid action of some drugs are more predominant, whereas some drugs have both glucocorticoid and mineralocorticoid action, where some have predominant mineralocorticoid action, and the immune suppression is mediated by the glucocorticoid mediated action. So we can use drugs with more specific glucocorticoid action for this purpose. So the dosing again is highly variable. In crisis scenarios, it might be a very high dose ranging from going even up to 1 or 2 grams, whereas in case of maintenance phase, it can come as less as 5 milligrams. So it entirely depends on the phase in which the patient presents, and higher doses are required in critically ill patients. Dose reduction is recommended in the remission phase, and the dose can be individualized on the patient to patient basis depending upon the patient's tolerance to adverse effects. It can be administered as monotherapy or as well as combination therapy with other class of drugs. Adverse effects which are seen at the doses which we use are secondary infections, sepsis, hyperglycemia, hypertension, Cushingoid features, behavioral disturbances, especially psychosis, myopathies, arthropathies, GI ulcers, and GI bleeds. So they are predominantly used in immune-mediated neuropathies, myasthenia gravis, CNS demyelinations, autoimmune encephalitis, bacterial meningitis, that is the pneumococcal meningitis, viral encephalitis, CNS vasculitis, and status epilepticus. So this tabulation shows the utilization of steroids in myasthenia patients, and we can see that it has shown, all the studies have shown significant improvement in overall outcome of the patients, as well as the drug over chronic use has produced remission in these patients. So these the effect of this group of drugs have already been established in myasthenia gravis, and in patients with chronic inflammatory demyelinating polyradiculopathy, the use of prednisolone was studied, and it has showed that there is significant improvement in patients who have received prednisolone. So steroids form a important tool in management of these patients along with other modalities. So this is a Cochrane review where the use of methylprednisolone and ACTH was studied in a group of patients with multiple sclerosis during acute exacerbation, and they have found that there is a significantly superior effect of methylprednisolone over ACTH when it is, and the effect is more predominant when it is administered intravenous formulation than oral formulation, and they can be more effective when the patient presents with an acute exacerbation. Coming to therapies which are targeting B cell depletion, with rituximab is the drug which is used, and it is an anti-CD20 glycoprotein antibody. It's a murine and human chimeric antibody. These CD20 cells are proteins which are expressed on the top of B lymphocytes. So basically, the rituximab binds to these receptors, thereby activating the lysis of these B cells through either complement mediated cytotoxicity or antibody dependent cell mediated cytotoxicity, or producing direct structural changes resulting in apoptosis as well as phagocytosis. So it is available as an intravenous preparation, half-life being 30 to 400 hours, and the excretion is phagocytosis in the reticuloendothelial system. It is dosed at 375 milligram per meter squared as a weekly dose for 1 month, and it is recommended to monitor CD19 and CD20 B cells to assess for the treatment outcome. The adverse effects are allergic reaction, sudden cardiac arrest, cytokine storm, tumor lysis syndrome, acute kidney injury, viral infections, progressive multifocal leukoencephalopathy, pulmonary toxicity, and bowel perforation. So this was the use of rituximab was studied in myasthenia gravis patients, and a review was done based on the isolated case reports and case series which were available, and it was found that this patients who have received rituximab, there was improvement in the functional outcome in terms of modified myasthenia gravis foundation of America post-intervention scale, the minimal manifestations of myasthenia, that there was 72% of patients with MuSK positive myasthenia gravis and 30% of patients with acetylcholine receptor positive myasthenia gravis. There is improvement in the functional outcome in terms of achievement of minimal manifestation stage, and it also showed that it reduced the treatment relapse when, especially in patients with MuSK positive myasthenia. So rituximab was generally tolerated well in this study, and the detectable serum rituximab mediated depletion of CD20 B cells were observed up to 20 weeks after a 4 weekly infusion. So other miscellaneous group of drugs which act at other parts of the immune cycle are complement inhibitors, antibody sequestration techniques, which includes plasma exchange intravenous immunoglobulins, FC receptor inhibitors, proteasome inhibitors like bortezomib, and there is chimeric antigen receptor T cell therapy, which acts at the level of antigen presentation only, and hematopoietic stem cell transplantation. So coming to therapeutic plasma exchange, that is one of the widely used modality in neurointensive care practice, where the plasma is separated from the cellular elements of the blood by centrifugation and ultrafiltration. This eliminates the immunoglobulins, complements, and immune complexes which are formed, thereby producing the effect. So the recommendations regarding plasma exchange are 5 to 6 exchanges, either daily or can be given on alternate days, and the volume is 1 to 1.5 volumes per cycle. So following a single exchange, there is 63.4% reduction in IgG and 68.9% reduction in IgM and 57.1% reduction in the complements. Whereas following 5 exchanges, it can go as high as 80.1% in terms of IgG, 79.5% in terms of IgM, and 59.7% in terms of complement. So the common problems which we encounter when we do a plasma exchange are CVC related complications like bleeding, infection, and pneumothorax, hemodynamic instability during the plasma exchange, bleeding, hypocalcemia, metabolic alkalosis, heparin-induced thrombocytopenia, as well as transfusion reactions. Coming to next group, which is the human pooled immunoglobulin. These are pooled plasma fraction of immunoglobulin which are obtained from donors, and the components include intact IgG, which includes all subclasses of IgG, IgA, IgM, soluble CD4 and CD8, HLA, and cytokines. Sorry. So There are various commercially available preparation depending upon the concentration of these immunoglobulins, osmolarity of the product, as well as sodium and the sugar content. And the preparation contains a stabilizing agent which prevents IgG dimer formation, which can result in release of pro-inflammatory cytokines, and it can trigger a cytokine storm. So it has a stabilizing agent to prevent it. Common routes of administration is the intravenous route, but there is subcutaneous preparation also is available. So the drug following administration equilibrates with the extra and the intravascular compartment, and it starts catabolizing gradually. Half-life of the drug is 18 to 32 days, and the half-life is more for a subcutaneous route of administration. The mechanism by which it acts are it can binds to the antibody as well as different it binds to the different zones of the antibody, and it can result in modulation and expression of the antibody as well as complement activation and degeneration of the antibody which is already formed. So coming to its applications, it is recommended for first line use in chronic inflammatory demyelinating polyneuropathy, Guillain-Barré syndrome, and multifocal motor neuropathies. And it is also recommended in as a important modality in the treatment of autoimmune epilepsy and neurodegenerative disorders, neuromyelitis optica, and other inflammatory myopathies and neuropathies. Coming to the dosing protocol, there is the induction regimen which is followed in the acute critically ill patient is a total dose of 2 gram per kg, which is given divided over a period of 2 to 5 days, and a maintenance dose of 1 gram per kg over 1 to 2 days every 3 to 4 weeks for 24 to 48 weeks. Whenever a patient presents with an exacerbation, again an induction dose can be given, or the dose which he is receiving as a maintenance dose can be increased up to 2 gram per kg over 2 to 5 days, and the interval of maintenance dosing can be shortened. So the adverse effects of immunoglobulin use, mainly it is concerned with the viscosity and the cytokine release property of the immunoglobulins. So the cytokine release can result in aseptic meningitis and other constitutional symptoms like a fever, and it can result in allergic reactions. The hyperviscosity can potentiate the risk of thrombosis. It can result in nephrotoxicity because of the sugar which is present in the preparation, and there is a risk of transmission of viral as well as prion diseases. So coming to the recommendation of different forms of immunomodulation, in Guillain-Barré syndrome, both plasmapheresis and IVIG are recommended as class 1 recommendation, whereas in case of myasthenia gravis also, both are recommended as class 1 recommendation. In case of CNS demyelination, all three group of drugs, that is the corticosteroids, plasmapheresis, and IVIG, all three are recommended as class 1 recommendation. So coming to paraneoplastic encephalitis and status epilepticus, so corticosteroids, plasmapheresis, and IVIG, all three are equally efficacious and they are recommended as class 2. So to conclude, there is no standardization of a specific therapy yet, but better understanding of pathophysiology of autoimmune diseases can result in development of a focused immunomodulatory technique with more benefits and fewer side effects. Thank you.
Thank you, Moulie, for the wonderful talk. Just want to ask you one question. See, sometimes when we use, you said IVIG and plasmapheresis are both equally efficacious for the disease like Guillain-Barré.
Yes.
When you use IVIG, sometimes you may not see the response that you would have expected, or patient would be deteriorating despite IVIG. In that context, or the other way around, use plasmapheresis, the patient would not be improving or expecting. You would expect the patient to improve, but they would not improve. So there's always a tendency to think of combining the immunotherapies, whether IVIG after plasmapheresis or plasmapheresis after IVIG. So such a practice does exist, and what does the guidelines say, and what did you go through when you did your research?
So when I did my research, the application of combined modalities of treatment is in practice, but it is recommended to start the plasmapheresis first. Followed by that, you can try an IVIG, but the response of that group is better always. But when it is done in the other way, that is initiation of IVIG followed by which administering plasmapheresis, that has not showed much promise.
All right, Mauli. So, did you come across IVIG use in the treatment of status epilepticus?
Yes, sir.
So, now how frequently are they used, and when should one use that?
So in case of status epilepticus, it is recommend like the possibility of autoimmune encephalitis as a cause of status epilepticus. IVIG is used.
Okay, and one another important thing where we use IVIG, especially in very high dose than what is recommended for Guillain-Barré and other diseases. No, you get sometimes the phenytoin induced adverse effects, the
Yes.
Steven Johnson
The-
syndrome, toxic epidermal necrolysis. We have used
yes.
in few cases, one or two cases whenever we encountered, and it is shown good results. So, what does the literature say with respect to using IVIG in those scenarios?
So with respect to those scenarios, yes, IVIG use has been tried, and they have shown good results, especially with patients who are presenting with drug-induced dermatopathies, basically toxic abdominal necrolysis, as well as phenytoin, Steven Johnson syndrome, and in patients who have developed DRESS, there are some case reports where people have even used IVIG to treat DRESS.
Okay, so it is a tradition whenever an IVIG is used to follow some pre-medication practices. It's very common in across the hospitals, across the institutions. It comes as a tradition. But is it really recommended by the guidelines, or it is just a tradition which is being followed everywhere by giving antihistaminics and before the paracetamol, preempting everything before giving IVIG? Is it really recommended when it is done under a monitored condition?
No, sir. No, the guideline doesn't recommend it. It is being used in practice as a habit. The recent guideline do not recommend any such things. Only thing which is recommended is adequate hydration.
All right. So, with the advent of technology, the IVIG preparation has also undergone market changes. So, with these IVIG preparations in the market, how common are the serious or life-threatening reactions to IVIG?
So, with the more and more available synthetic formulations, as well as the drugs with low osmolarity, the serious adverse effects like renal failure, all those things are very less. And taking adequate precautions, it can be safely administered. And I think it is tried in practice day in and day out by a lot of neurologists very safely.
All right, Mauli. Thank you for your wonderful presentation and insights into the immunotherapies, which everybody should know who's practicing neurocritical care. Thank you, Mauli.
Thank you, sir.
Thank you, everyone. Let's meet in another chapter of the classroom. Till then, bye. Happy weekend. Thank you.